A very warm welcome to everyone. So today we are here
Video.
with with Dr.
Video.
Arun, who is a renowned consultant gastroenterologist from Apollo Main Hospital, Grimstone, Chennai. He is also a director of Chandra Gastro Clinic and Endoscopic Center, Chennai. His area of interest is post-liver transplant guidelines and plasmapheresis in ACLF. Along with that, he is also a life member of ISG, INSL, SGI, and IAP. Today, I invite you all and we cordially invite every one of you to this webinar. Today's topic is optimal management of acute severe ulcerative colitis. Uh, Thank you, doctor, for being part of this uh, webinar. So over to you, doctor.
Thank you, CIPLA team, to give me an opportunity to be here in this forum. And good evening, respected professors, senior consultants, and my dear friends. It's really a great pleasure for me to take over the discussion about optimal management of acute severe ulcerative colitis. If you're going to discuss something about ulcerative colitis, it's such a big area. If you're going to start right from the etiopathogenesis, from clinical features, from mild to moderate, from moderate to severe area of discussion, it's such a big area of presentation. So my area for today's discussion is right now mainly to talk about acute severe ulcerative colitis. So what do you mean by this acute severe ulcerative colitis? To start with the discussion, I would like to take over a case scenario, so which was happened recently in June 2020. So here, a 28-year-old male who presented to us with history of colic abdominal pain for a duration of almost 2 weeks, which is also, he presented to us with issue of increased frequency stools, more than 5 to 6 episodes a day, with admixed of with blood and mucus discharge also happens per rectum. So, along with this patient is going to presented with issue of low grade fever. And when we took this history and we did a basic colonoscopic examination for this patient, which showed clearly, to whom we have done a colonoscopy up to splenic flexure. So in that we have been seeing all the basic findings of the acute severe ulcerative colitis. The biopsy has been proven for the patient. And we have done a CECT abdomen for this patient, which showed evidence of normal steady. And this patient was initiated on mesalamine support at that point of time, followed by 4 months later, he presented to us with moderate disease activity, which is still persisting, followed by the patient initiated on a oral steroid preparation of almost around 40 milligrams. And during this period, over the period of time, the prednisone was consequently tapered off, and azathioprine being added along with mesalamine also being continued. So the patient was compliant to this drug and symptomatically is better during this initial period of follow-up. So now the patient has been admitted to us in the current scenario, henceforth. So 5 days history of pain abdomen along with diffuse colicky pain, which is dull aching, increased frequency of stools, and which is almost around 10 to 15 episodes per day, and blood and mucus discharge is also happening right now, along with tennis, which means the painful passage of stools is still there, followed by the appetite is good, but that shows some evidence of unintentional loss of weight. But apart from this, the patient doesn't have any evidence of extra GA manifestations like blurring of vision or any joint symptoms or anything like that. Past history of no UC been diagnosed for this patient 8 months ago. Apart from the no major comorbidities, he's a social drinker and no similar family history or GA malignancy which has happened in the family. And when we examine, the patient doesn't show any major evidence apart from he's pale to look at, and vitals almost stable, and cardiovascular and other systems are normal. A periabdominal examination, there is mild diffuse tenderness which has been there, which was along with no other organ megaly was there. So when we have done the viral markers and COVID screening, all those things being negative, and we have done an X-ray erect abdomen to this patient, which shows normal, and ECG also normal for this patient. So the basic blood investigation for this patient shows evidence of anemia in the background of hemoglobin around 8 grams. Apart from that, the patient total count is almost okay, liver function is okay, and albumin is almost in the normal range, 3.5, amylase and lipase, everything is okay, with RFT is also maintaining the normal range. So in this background, So why I'm taking this presentation? So for to analyze how the event of ulcerative colitis is being progressing to this patient, and how do you going to approach when you're going to tackle this kind of case scenario. This is the most important thing for you to understand the background, because our area of intention to discuss mainly about the management of acute severe ulcerative colitis. See, any physicians or surgeons who are going to present with, so yeah, I mean, whoever is going to tackle with a mild moderate presentation, they can initiate with 5-amino salicylate basic preparation, followed by, once the patient is going for acute severe ulcerative colitis and the patient really deserve a emergency intensive care, which is acute emergency, followed by the gastroenterologist role is going to be in a predominant area. In this kind of scenario, how are you going to approach? That's my area before taking over the discussion about the management of acute severe UC. So when we do for this presentation, the background of anemia, followed by initial presentation and again worsening of symptoms. The patient on day one initiated on a first line of antibiotic support like ciprofloxacin and metronidazole, along with the patient being continued with steroids since the patient doesn't show evidence of any septicemia, along with the patient being also on azathioprine and mesalamine support was there. And day 6, the stool frequency still remains 6 to 7 times per day as per true love and Witt's criteria, which means its severity index is slightly in the higher side. Followed by, once this presentation happened, so we have decided to switch over to injectable steroids. So injection hydrocortisone has been taken over, followed by, once this patient being started on injection hydrocortisone, the stool frequency still worsened, which has almost gone up to 15 times. So we have added around, a higher dose of antibiotic support, and we have stopped the scenario. With this kind of scenario, made us to stop steroids indeterminately, followed by this kind of worsening presentation. So if the patient's hemoglobin, right, see, if you're going to look into this graph, the hemoglobin is going around 8 grams, still anemic is persisting, along with the total count is still in the higher side now, it's gone up around 24,000. So apart from that, the albumin, everything is in the normal range, and RFT is still mainly normal. And for this kind of patients, we have done the basic workup, X-ray abdomen, everything shows normal. And to him, we have done a video colonoscopy, which shows a Mayo severity score of almost around 2, and we have done a biopsy to rule out cytomegalovirus or any other infections being there to supervene. And day 12, the patient becomes afebrile, and stool frequency, everything has come down, and this patient will be evaluated for a biological support, whether this patient deserve this kind of treatment is there or not. So this ulcerative colitis, if you want to take into this discussion, so how are you going to categorize this patient? So it could be because of steroid dependent. So if you're going to look into this ulcerative colitis, the main area of management for mild, moderate, or severe, we need to categorize this patient, whether it falls in the mild, moderate, or severe. And this kind of presentation, which is being initiated on first line of medication, followed by the patient worsening. And once the patient gone up to higher dose of steroids, this patient showed some response initial phase, followed by worsening of symptoms like septicemia, which is being progressing, and the patient being forced to land up with the second line of medication. In this kind of scenario, how are you going to approach this kind of patients? It's the most important area for me to take on. So what do you mean with whether the patient is steroid dependent, or whether the patient is steroid refractory, or this occurs during the scenario of steroid tapering? And apart from that, how are you going to proceed with colonoscopy if the patient is going to have severe colitis? Whether this is having early relapses or immunomodulator refractory. What do you mean by immunomodulator refractory? When to consider the patient for biological support, and when you're going to refer the patient for surgery. If you're going to, these are all the area of outline what you're going to discuss right now about the management of acute severe ulcerative colitis. See, if you're going to take in this discussion, what do you mean by the treatment strategy? How are you going to divide this treatment strategy for this ulcerative colitis? See, what is this acute severe ulcerative colitis? If you're going to look into that, if the presentation, so it can be divided into proctitis or left-sided or extensive colitis. This is how the treatment approach for ulcerative colitis is going to be determined. So what do you mean by this proctitis? If the patient going to present within 18 centimeters of anal vein, if there is evidence of any worsening of symptoms, then it is only proctitis. If the left-sided of colon, if they up to extending from sigmoid to splenic, if it is going to be involved, then it is left-sided colitis. And once the entire colon beyond the splenic flexure, even if the transverse and right side of colon, if it is going to be involved, then it is called extensive colitis or pancolitis. So if this kind of presentation is going to happen, the most widely used, the multiple indices being used to assess the severity for adults, also for pediatric population. So pediatric entity is a different one rather than when you're going, our intention is mainly to talk in adult entity. So mainly about, we are going to take over about what is medium in by true low and width criteria. There are other multiple indices can be considered in managing this kind of patients, like modified Mayo's and Montreal's classification, Sears index, so many other things, SCAI, so many other indices are being there to assess the severity. And Montreal's classification be based upon the extent, whether it is being E1, E2, or E3, based upon that, this is going to be categorized. So the first thing, modified true low and width criteria. What is this true low and width? See, if you're going to look into this, whether it is mild, moderate, or severe, as per our clinical scenario, if the patient is going to be going to have bloody stools for more than 6 stools per day, and if the patient is showing evidence of significant tachycardia for more than 90 beats per minute, in the background of worsening of temperature, in the background of low hemoglobin, along with the raised ESR if it is going to be more than 30, and some scenarios, if even ACG guidelines have mentioned that the scenario of ESR can go even up to 75 in this kind of worsening patient presentation, and the CRP if it is going to be more than 30, which shows evidence of a severe ulcerative colitis is happening for this kind of patients based upon the clinical presentation and based upon the basic blood investigation. So this pointer itself can be taken into an account. So this Mayo score, not only based upon, this is another scoring system we are going to use for categorization, and the score range from 0 to 12. So in this kind of presentation, we are going to assess a clinical presentation, also your endoscopic presentation. In this clinical presentation, we are going to look for stool frequency, we are going to look for rectal bleeding, we are going to look for mucosal appearance, and the physician assessment, whether the patient is having evidence of severe or mild to moderate disease. We need to assess this clinical scenario. And one thing, if the patient is going to have frank blood which is going to pass, which means the rectal bleeding is almost in stage 3, and stool frequency, if it is going to be more than 5, which means it's almost in stage 3, and mucosal appearance, it's most important to be considered, because if you're going to do a colonoscopy and you are doing, see, if the patient is going to have acute severe ulcerative colitis, unprepared colonoscopy is the most important thing to be taken over, and you should not prepare the bowel much, and you are not trying to make an attempt to screen the entire bowel for this kind of patients if you're going to do a colonoscopy. So the mucosal appearance is the most important thing. And if the patient's categorized as mild disease, means there may be erythema or decreased vascular pattern or mild friability could be there. Once the patient is going for a moderate disease, it shows marked erythema and absent vascular pattern with friability, and erosions will be there. Ulce the patient is going for severe disease, even if you're if your colonoscopy is just going to breach a mucosa, that shows evidence of spontaneous bleeding, and ulceration will be there for this kind of patients, and polypoid and pseudopolypoid appearance also may develop in the extensive phase. So this kind of patients also we need to do a global assessment to categorize the patient as severe disease or not. Based upon that, the Mayo severity indices for ulcerative colitis can be determined. So once you are going to assess the severity for ulcerative colitis, and how are you going to manage this patient? So once this patient been diagnosed as evidence of acute severe ulcerative colitis, it's a medical emergency. The patient need immediate hospitalization, the patient need IV fluid support, the patient may need blood transfusion, the patient may need first line of management, unless and otherwise if they were not going to initiate on first line of management, the patient may develop a florid septicemia, followed by the patient can collapse on table also. So this is the most important thing, the most important prediction based upon your clinical parameters, your hemodynamic assessment, your basic blood parameters. All those things will be taken over into account if you're planning to manage a patient with acute severe ulcerative colitis, which is a medical emergency to be concerned. Almost initial phases, if you're going to look into this, if you're not going to manage this patient right time, the mortality will be going up to 20 to 75% initial phases. But now the mortality for severe ulcerative colitis has been significantly come down in most of the centers, so almost around 1 to 2% is going to happen. So if it's almost approximately 20% of the ulcerative colitis patient with initial disease phase have evidence of severe UC, and about 15% of patients have severe attack at some stage of the disease. So always you should remember this basic data which has been taken over from the World Journal of Gastro. So this is the most important thing. So unless and otherwise, if you're not going to intervene this kind of patients, the patient may land up with worsening of presentation. Once the clinical presentation with the worsening of ESR, CRP, high stool volume, reduced hemoglobin with hemodynamic instability, with a significant evidence of clinical picture which is being happening for this kind of patients, what is the basic investigation you are going to do? Even if the patient is the first episode, or even if the patient is having a known case of UC with worsening of presentation, with flaring of symptoms. So what is the first line of investigation we are planning is basic blood counts, along with your liver and kidney function test. And always you need to measure the electrolyte abnormality, because the toxic megacolon and other complications can be precipitating if the patient is going to have some sort of electrolyte abnormalities. Always also you need to check for your sodium, potassium, as well as magnesium levels, and CRP, ESR, to assess the severity of your disease. And always you need to take 3 stool samples for antibiotic associated colitis toxin, which is nothing but Clostridium difficile. So it should be obtained for all these patients, because this kind of patients may have superimposed pseudomembranous colitis. So also we need to take this kind of patient 3 stool samples for Clostridium difficile toxin and asked to be taken. We can do either PCR based assay, laser based assay can be done for this kind of patients. That's the most important investigation also to be considered in the management of UC, acute severe UC. And always you should remember, and you should not forget to take a plain abdominal X-ray, which will clinches of a most important clinical picture when you are going to manage a patient with UC. So what you're going to do, a plain abdominal X-ray. So the most important thing, once a patient is going to land up with the symptoms of severe or fulminant colitis, what is going to happen? The patient may develop a thumbprinting appearance, which is due to a thickening of the colonic wall plus bowel wall edema. So if I will show you the picture, so if you're going to see in this, so this is the thickening of the colonic wall. Bowel wall edema is being very significantly characterized for this kind of patients once a patient is going to develop a thumbprinting colitis. And toxic megacolon also can develop. The bowel wall is significantly dilated with loss of postural marking. So if you're going to look into this, this is a toxic megacolon, and there will be evidence of a mucosal islands, which is being creeping of mucosal islands will be there in this kind of patients. If you're going to look into this kind of clinical presentation, so X-ray abdomen is the most abdominal X-ray is the most important thing. So what are the various poor prognostic factors, the prediction of features that predict poor response to treatment in your X-ray? If you're going to identify a mucosal island, that what I've been discussed, a small circular opacity representing residual mucosa isolated by a surrounding ulceration, and more than 2 gas-filled loops of small bowel on the radiograph. So if you're going to look into that, more than 2 significant gas-filled loops are there, and significant mucosal island formation will be there with evidence of toxic megacolon. This shows a clinical pointer to clinical suspicion to rise in terms of ulcerative colitis, which is going for a severe presentation. And if you are going to plan a colonoscopy, immediate colonoscopy is the most important thing. Within 24 hours of the presentation, or at most within 72 hours, we need to plan a colonoscopy for this. And most of the time, we plan a flexible, unprepared sigmoidoscopy with very minimal air insufflation. And don't try to inflate more of air, and don't try to look into the entire colon. Always inflammatory bowel disease is one entity where it comprises of UC as well as Crohn's. As we all know, UC, which is predominantly being located into your large bowel, but your Crohn's disease will also be radiating to the entire area from your upper GI to lower GI pathology. And this kind of patients, if you're planning for a colonoscopy, don't think always we need to intubate the terminal ileum, because once a patient is going for acute worsening of presentation in the background of severe edema, friability, bleeding, mucosal erosions. So for this kind of presentation, so always you just don't prepare too much. An unprepared sigmoidoscopy is the most important thing. With minimal insufflation can be done. And also you look for a superimposed infections like cytomegalovirus or Clostridium difficile. All those things can be, we need to have a look on that when you're doing a colonoscopic examination. And apart from that, endoscopic markers of severe disease. What are the various markers? There are various scoring systems that are already been shown. So once a patient is going to land up with severe disease, what are the various markers in touching bad? Hemorrhagic mucosa. Once you're going to touch with your colonoscope, the patient will start bleeding. Hemorrhagic mucosa, deep ulceration, and mucosal detachment will be there. A deep, like a excavated ulceration, if it is going to be there, that shows the evidence of a worsening of presentation. So within 72 hours, we need to do a flexible sigmoidoscopy with minimal air insufflation is the most important point to take on right now. And these are all the characteristic features of UC. See, if you're going to look into this picture A, so this picture A, which shows only mild mucosal erythema and fine granularity with decreased vascular marking. So if you're going to look into your colon, you can able to see more of vascular marking. So in this kind of patients, they are showing only mild picture. So there will be around minimal mucosal erythema is there. If you're going to look into this picture, which shows evidence of marked erythema, so along with the vascular markings is completely gone with multiple erosions is happening. So this kind of patient is having evidence of a knotted picture. And once the patient is going for evidence of multiple ulcers, which means it shows evidence of severe disease at the onset of presentation. And if you're going to look into this slide, that shows evidence of spontaneous bleeding, which shows a worsened presentation, a severe presentation. Once a patient is having luminal narrowing, in which it's very difficult for you to negotiate your colonoscope with evidence of polypoid lesion and pseudopolypoid presentation. If you're going to take on this slide, so this shows evidence of severe worsening presentation of ulcerative colitis. So this is about ulcerative colitis indices. Where are the various indices which is being here? UCEA score and along with Mayo score, along with endoscopic features, all these things can be taken into account. If you're going to see based upon the Mayo and UCEA, so ulcerative colitis indices, if you're going to think into that, so it can be categorized as normal indices. See, if you can able to see the well arborization of the mucosal, all the vessels are being well arborized. Apart from that, once a patient is going to land up with erythema, the severity is slightly increasing, mild friable mucosa. And once a patient is having marked erythema with more friable mucosa, which shows evidence of 4 to 6 of UC severity indices, along with severity of around 2. Once a patient is even just breaching the mucosa, if the patient is going to present with evidence of spontaneous bleeding and ulceration, it shows evidence of UCEAs almost around 78 and Mayo severity, which is going to almost around 3. Once a patient is going to land up with this kind of presentation, how are you going to approach, how are you going to tackle is the most important thing, because always you should remember managing a patient with IBD is most of the time a chronic presentation. You need to counsel the patient, you need to counsel the attenders, you need to talk to the patient, you need to follow the patient. Consecutive follow-up is the most important. We need to prevent this kind of patients to develop colorectal malignancy and other pathology. All these things have to be taken into account when you're going to manage a patient with UC, assessing the severity and following up the patient, proper initiation of care, and stepping up and stepping down of therapy is the most important thing when you're going to manage a patient with UC. So if you are going to look into this UCEA's ulcerative colitis endoscopic index of severity, this is what I've been discussed as based upon 4 pointers. One is by vascular pattern, that what I've been discussed, and next to that by bleeding, and next to that by erosions and ulcers. So these are the 3 pointers which have been taken into account. The vascular pattern, bleeding, and ulcers based upon your scoring system will be 0 to 2 or 0 to 3. And once the patient is having erosions and ulcer, which is going to be more than 5 millimeter, which shows evidence of a stage 2 disease. And once a patient is going to be a deeper excavated ulcer, which means a stage 3 pattern of disease. And bleeding, which shows once a patient is having flank bleeding, shows evidence of stage 3 disease. And once a patient, even with minimal blood oozy is still there, which shows evidence of an stage 2. And the vascular pattern, if it is completely obliterated, if it is going to be completely lost, it shows evidence of vascular pattern stage almost 2. So vascular pattern, bleeding, erosions, and ulcers are there to take over this discussion. So mainly to discuss about this acute severe UC, and based upon ACG guidelines, ECO guidelines, so all this statement, how they are going to proceed with that. So once the patient is going to, what do you mean by the definition? Because as a postgraduate, we all should remember the various definitions will be there, even for a MDM or DNB PGs who have been looking into that. What do you mean by the term remission? Which means the complete resolution of symptoms with endoscopic healing is also being there. And your stool clinical presentation, like your stool frequency, also if it is going to come less than 3 per day with no bleeding and no urgency, it shows clear evidence that the patient is going for a state of remission. Then what do you mean by relapse? So in this kind of presentation, once there is a worsening of symptoms in the background of established ulcerative colitis, who is in a clinical remitting phase, which shows with spontaneously worsening of symptoms after initiation of medical treatment, it shows clear-cut pointer that the patient is going for relapse. What do you mean by this early relapse? So early relapse, if it is going to happen within a period of 3 months after initial improvement of symptoms, is nothing but early relapse. And what are the various patterns of it? It could be infrequent or it could be infrequent. What do you mean by what do you mean by frequent relapse? If it is going to happen more than 2 per year, and infrequent means if it is going to be happen less than 1 per year. So based upon whether it is a continuous persistent symptoms of active UC without a period of remission, which means it could be infrequent, frequent, or continuous. So all these things we all should remember about the basic definition of managing a patient with ulcerative colitis. What do you mean by the terminology called steroid refractory and steroid dependent? So because these two definitions are always important, not only for the management of other conditions, also when you're going to consider the patient for acute severe ulcerative colitis, when you're going to subject the patient to second line molecules, when you're going to consider the patient with biological support, all these things has to be considered based upon the steroid response is there or not. When you're going to define this patient as steroid refractory, patient who have active disease despite oral prednisolone of around 1 milligrams per kg per day over a period of almost 4 weeks, or intravenous steroids if you are going to subject the patient for 1 week after infectious complications are excluded. So oral steroids means up to 4 weeks, and IV steroids up to 1 week. If you have the patients, even after that, if the symptoms are still worsening, it shows evidence of a steroid refractory. Steroid dependent means you couldn't able to taper the dose, but once you're going to try to taper the dose of almost around 10 milligrams per day within a period of 3 months of starting steroids, and it shows the patient may have recurrent of active disease, or the patient may show evidence of relapse within the period of 3 months of stopping steroid. It shows evidence that the patient is always steroid dependent and they need to continue the steroid for a longer duration of time in these kind of patients. So to take on the discussion about the new entity of being given, which is being given in the American ACG guidelines, what do you mean by this immunomodulator refractory colitis? The patient who have active disease or relapse despite the use of azathioprine or 6-mercaptopurine after dose of maximum dose for at least around 3 months of optimal duration, according to the 6 thiaguanil levels are being considered. And always you need to measure all these things. Even after that, the patient shows evidence of active disease. It shows the immunomodulator refractory UC. So once the patient is being decided to be in the diagnosis, the main area for discussion right now been taking over about the management part of acute severe ulcerative colitis. The acute severe, the Mayo indices is being worsening along with UCAS, a severe fibrosis, mucosa, bleeding, other complications, and the patient is going for evidence of dehydration, shock, and other kind of presentation in the background of septicemia. And always you should remember it's a chronic presentation, and we need to take on the patient to bring out the acute worsening of symptoms. The most important thing, the IV electrolyte and fluid correction is the most important, along with potassium supplementation. Is almost around 60 millimoles as per new ACG guidelines is usually necessary. And most of the time, this patient is recommending a dose of low molecular weight of heparin prophylaxis. Always is remember we need to give, because this is always a procoagulant state. The patient may have evidence of risk of thromboembolism. So subcutaneous prophylactic LMWH is also most important to prevent the risk of thromboembolism in this kind of presentation. And nutrition support if the patient is malnourished. So what do you mean by this malnourished that I'll be discussing with you? So once a patient BMI, if it is going to be less than 18.5, the patient shows evidence of malnutrition. So, and you can take on this kind of patient. Once a patient, he can either enteral nutrition or parenteral nutrition can be done. But enteral nutrition is the most important thing if you're going to manage this kind of presentation, rather than going for parenteral nutrition, because parenteral nutrition may have higher rate of complications as per the ECO guidelines question statement from 2017, what they mention about that. And if you're going to use other drugs like anticholinergics and antidiarrheal NSAIDs and opioids, all these things will worsen your toxic megacolon-like presentation. All these molecules has to be stopped. The over-the-counter medications you're not supposed to use, and topical therapy like topical steroids, topical 5-aminosalicylate preparation, all these things will not be much efficacious once those systematic studies being proven once the patient is going to land up with acute severe colitis. So antibiotics can be considered only if the patient is going to have a supervening infection, or if you are going to plan the patient for a surgery. And blood transfusion, always we need to target a hemoglobin more than 8 grams per deciliter. That's the most important thing. And once a patient been diagnosed with ulcerative colitis of acute severity, the most important thing we need to consider about IV steroids. IV corticosteroids is the most important. And other than that, a therapeutic alternative for the rescue of steroid refractory disease, we can also consider cyclosporine, tacrolimus, or infliximab are considered early on around day 3 of steroid therapy, and that the decision-making process should not be delayed at any point of time by a gastroenterologist when you're going to manage a patient with acute severe ulcerative colitis. So the most important thing we need to discuss, if you're going to, this is how the drug delivery site, this is the outline. If you're going to look into that, how the systemic glucocorticoid therapy is going to, the first pass effect will be there in the liver, approximately 20% is going to happen, and it will be distributing into the active substance into various areas. So based upon how you're going to give your prednisone and other things. So the most important, if you're going to use either methylprednisolone or hydrocortisone, is the first line of therapy. If you're going to use a patient with steroids, IV corticosteroids has to be initiated. Methylprednisolone means 60 milligrams 24 hourly, and hydrocortisone at 100 milligrams 4 times daily can be considered. But this kind of things we can consider for a period of around 3 to 5 days. A treatment should be given for a different period, but as extending therapy beyond 7 to 10 days doesn't yield much of benefit to this kind of patients. Higher doses also no more effective as per the World Journal of Gastroenterology statement what I mentioned. So no need to go for this is how we are going to titrate the patient along with the managing a patient with ulcerative colitis, and you need to see whether the patient is responding to the medications that's there or not. So what are the factors that predict steroid failure in acute severe colitis can broadly divided into 3 major entities based upon your clinical picture, based upon your biochemical picture, based upon your radiological picture. So what are the various clinical pictures? So if you see, as I discussed with you, once a patient is not responding to your steroid, which means your stool frequency is still going high. Within 24 hours to 48 hours, the frequency of stool, if it is going to be more than 12 per day, which means it shows that patient has a high possibility for this kind of patients to land up in surgery. So the patient can go for colectomy at a rate of almost around 55% of this kind of patients. Once the patient frequency, if it is going to be more than 8 per day, or if the patient is having if the patient is having 3 to 8 episodes of stool frequency along with the high CRP value, more than 45 on day 3, this kind of patients, as per Oxford criteria, what they may mention that the patient, there is high possibility for them to go for colectomy. And this is how, based upon your clinical picture and ESR, biochemical markers in the background of around more than 75 with a significant elevation of temperature more than 38, which shows a high possibility more than 5 to 7 folds, 10 folds increase for this kind of patients to go for colectomy. And radiological criteria, it shows evidence of toxic megacolon, chronic dilatation, the transverse colon diameter, if it is going to be more than 5.5, or as I discussed with you in my earlier slides, if the patient is going to present with evidence of mucosal islands, so there is high possibility for this kind of patients to go for colectomy. So how are you going to approach this acute severe ulcerative colitis based upon your clinical presentation? That is how this is a treatment algorithm outline. So if you're going to discuss about this, acute severe ulcerative colitis being diagnosed as per True-Love-Witt's criteria, you are going to initiate the patient on steroids. So we need to classify the response as per our Oxford criteria, as what I've been discussed with you. We need to categorize the patient as complete responder or incomplete responder or non-responder. Once the patient is going for complete response, which means the stool frequency definitely coming down, then the patient can switch over to oral steroids, and we can add azathioprine at a rate of around 50 milligrams. So we can continue at a lower dose of steroids can be maintained for a period of time. Once a patient is going to show some incomplete response or non-response, which shows evidence of worsening of CRP, worsening of a clinical presentation, worsening of stool frequency, then you need to go for a rescue line of medication, the second line of medications, or you need to consider the patient for biological support, or you need to consider the patient for colectomy. So once a patient, what are you going to do on day 4 to 7? We need to categorize. Once a patient is going for complete responders, we need to switch over the patient to steroids, because you are not supposed to give IV steroid for more than a period of 3 to 5 days. And most of the time, your steroid, IV steroid should not go beyond 7 days. So we are followed by, once a patient initiated with IV steroids, we need to switch over to oral and azathioprine and steroid dose. All those things has to be assessed in a proper manner on day 4 to 7 prior to decide whether the patient deserves a surgical intervention is needed or not needed. As per the eco position statement, the European consensus guidelines, what I mentioned about that, the patient, so initially, if you want the patient is going for a maintenance therapy, 40 milligrams per day for first 1 week, followed by lowering the dose every 5 milligrams followed by a 8 weeks course of therapy to be considered after giving the patient with oral steroid, IV steroid, and followed by the patient can go for shorter steroids. Also, some patients been tried, but what will happen once you're being initiated with the shorter course of steroid, that shows evidence of significant relapse during this kind of presentation, or sometimes will be ineffective for this kind of active disease. And always you should maintain a good dose of steroids and tapering in an effective manner. And you need to continue the dose of steroids almost approximately 8 weeks during once a patient shows evidence of clinical symptom, clinical improvement of your symptoms following the management of acute severe ulcerative colitis. This is all the basic steroid side effects as well known, nothing much to discuss in this slide. The various mood disturbance, acne, strain, hirsutism, the patient go for adrenal suppression and other things, major complications, type 2 diabetes worsening, glucose intolerance. These things can worsen if you're going to manage a patient with steroid. And this is how your second line of medications like rescue therapy, when you're going to add the second line of therapy, how are you going to act? So always when you're going to subject the patient with maintenance tapering dose of steroid, you can add the patient with azathioprine support. How the azathioprine is going to act, this is how the clinical outline of picture which has been taken recently. So this azathioprine will be converting into the active metal 6-mercaptopurine. From there, it is going to convert them into 6-thioguanine form, which is the active metabolite. So this is how the azathioprine, if you're going to look into this, how to start the therapy, how to optimize the therapies. This is how the most important thing. And 6-mercaptopurine, and from 6-mercaptopurine, 6-thioguanine metabolites will be forming, and followed by the subject will be going for apoptosis, and thioguanine release is going to get happen. So this is how the optimization of your azathioprine has to be done, and how to start, and some side effects of azathioprine as well. No, we need to monitor this patient with basic blood parameters, and sometimes various ITs like pancreatitis and hepatitis can supervene. And always you should remember, if you're going to subject the patient for a longer duration of azathioprine, the patient can develop a secondary lymphomas and other presentation. And this is how the again outline, if you're going to look into that, whether the patient is going to start on azathioprine support along with azathioprine naive patients, means once a patient being switched over to IV steroids, we can assess the patient every 3 to 7 days, and bloody diarrhea, whether it is persisting or not. Once the bloody diarrhea it's going to be persist, then we need to add the second line of molecule. Either we can go for IV cyclosporine or we can go for infliximab support. So IV cyclosporine means we can give at a rate, but most complicated presentation, what you're supposed to remember that once a patient being subject to cyclosporine and another line of molecule, there is high possibility for this kind of patients to show high mortality. So always cyclosporine should be a reserve line of drug when you're going to consider this, because a renal complication and other things will be there when you're going to manage this kind of patient with cyclosporine if the patient is going to show no response even after initiation of azathioprine. Whether the patient is going to consider for biological support like infliximab, a monoclonal antibody, if you're going to consider, and so the only thing when we are going, the problem is we need to rule out other possible infections when you're going to use a monoclonal antibody, and the cost and other issues which is being more common in the Indian scenario. So monoclonal antibodies also can be considered in the management. So we need to assess the clinical improvement is there on day 5 to 7 or 7 to 10. Based upon that, whether we need to continue this patient with steroids along with the cyclosporine support, or else whether the patient is going to be on biologicals to be continued or not. All these things has to be taken into account if you're going. Once a patient shows evidence of azathioprine failure, directly we can go for the patient with biological support, and or else the patient can be subjecting for a surgical line of management, or a sequential therapy like cyclosporine or tacrolimus can be considered in the management of presentation. So step-up approach, see, based upon your pharmacogenomic therapy like your polymorphism, your TPMT, that means thiopurine methyltransferase activity levels has to be assessed if the patient is going to subject with thiopurine support. So the initiation of dose will be around 2 to 2.5 milligrams to be a period to be considered in the management, and also you should monitor your blood parameters when you're going to manage a patient with azathioprine support. So step up, we can start with 25 milligrams or 50 milligrams, and slowly you're monitoring all blood parameters has to be done. The second line of drugs has not been discussed. Cyclotherapy and monotherapy can be considered over steroids, who have high chances of side effects of steroids. Patients can be having a steroid related osteoporotic, diabetic. For this kind of patients, we can consider, but there are major side effects as I have discussed with you: neurotoxicity, hypertension, renal worsening symptoms. Sometimes the patient may deserve a renal biopsy prior to initiating a patient with steroid. All these things are there to monitor. And once a patient being subjected to cyclosporine support, these kind of patients can have high mortality. That's the most important thing to be considered. And a very important parameter, once a patient is having low cholesterol levels or very low magnesium, don't use this patient with cyclosporine. And also your basic blood parameters, your electrolyte abnormalities, your cholesterol, your lipid values, also your basic RFT, all these things has to be measured in a prompt way if you're going to manage a patient with cyclosporine. And to start with, in 2 milligrams per day intravenously, aiming for a levels of trough almost around 150 to 250 nanograms per ml can be done. Once a patient shows worsening of creatinine, always you need to stop the molecule. This is how the cyclosporine response, if you're going to look into this graph, which has been taken in World Journal. And so once a patient, azathioprine naive patients, if you're going to initiate with cyclosporine support, day 4 to 7, we need to assess a response, and we can add on to oral cyclosporine on the azathioprine also can be continued. But if the patient, either if you're going to do, once a patient shows evidence of resistance to intravenous steroids, either cyclosporine or infliximab can be considered. Once a patient being tried with infliximab, again, we need to categorize the patient with response is there or not. If there is inadequate response, the patient can go for a colectomy and other procedures. So responders, intravenous cyclosporine should be switched to oral cyclosporine. 4 milligrams per day, twice daily can be considered. Azathioprine should be started along with oral cyclosporine. And cyclosporine not supposed to continue after a period of 3 months in the management of ulcerative colitis. So these are all the other second-line rescue molecules like tacrolimus. As you all know, it's a calcineurin inhibitor, which is almost a mechanism of action similar to the cyclosporine. And if you're going to see, various trials have been shown some response in severe UC, and a randomized trial shows included more than 27 among 60 patients, 27 population, and shows some evidence of response. So what they've been seeing, the partial response was seen in almost 67% of patients, although complete remission will not be there most of the time if you're going to manage a patient with tacrolimus. This is all the biological disease. This is the most important thing to be considered in the management of acute severe ulcerative colitis. This is the final line of medical line of care, what we are available. And there are so many innovations, biosimilars and other things which is happening for the management of ulcerative colitis. And the first line of molecule like infliximab, if you're going to start, or adalimumab, and other drugs like vedolizumab or golimumab, these things can be considered pointers. The most important thing, infliximab and adalimumab, if you're going to show, that shows significant beneficial effect in the management of UC, along with golimumab. Also, there are some papers being evidence to document that, and vedolizumab also been considered. And what is this infliximab? It's a chimeric antibody. Adalimumab is a recombinant human IgG. And vedolizumab, if you're going to look into that, it's a humanized IgG. And apart from that, golimumab also is a humanized IgG monoclonal antibody. There are various formulations are there, the various doses, and this is how the outline of the diagram, how it is going to act. So based upon the T helper cell response, apart from the MATCAM molecule, whether the patient, all this nadunolimab and all that's proven beneficial role in Crohn's disease and other management, TNF antagonist effect, and interleukins 12 and 23 antagonists, interleukin 23 antagonists, was a various molecule, how it's going to penetrate into gut epithelium, and from there to blood vessel, and from there how it is going to affect your mucosal presentation, how the patient is going to improve the severity of your UC. This is how been the area of discussion right now. So infliximab can be tried as a salvage therapy, and moderate to severe disease can be tried as a salvage therapy. It's a TNF alpha inhibitor, as I discussed with you. The mechanism is mainly by a monoclonal antibody chimeric IgG form, which almost induces a T cell apoptosis. So what is going to happen? It's bind to a TNF alpha and neutralizes effect and induces T cell apoptosis in your intestinal cells and peripheral blood monocytes. The most important thing, always you should remember when you're going to initiate the patient with infliximab, the dose is most important, because 5 milligrams at 0, 2, and 6, and maintenance every 8 weeks we can give, followed by sometimes we can increase the patient to 10 milligrams also if the patient doesn't show much of response in the initial phase. 10 milligrams per kg also can be considered, and slow infusion to be given. And even if the patient is going to have prior thiopurines and other drugs, if you're going to use for this kind of patient, no need to worry, you can continue safely infliximab also for this kind of patients. and various trials to prove this beneficial role, like ACT trials for UC. There are two randomized Act 1, Act 2, multiple trials are there. And if you're going to look into this Act 1, Act 2, what they've been given for a period of almost 8 weeks induction phase, followed by maintenance for a period of 54 weeks. If you're going to give, that shows a significant response for infliximab at a dose of around 5 milligrams per kg. So moderate to severe UC, definite beneficial role is there if you're going to start the patient on infliximab. But there are some factors which adversely affect your outcome, like your baseline CRP, if it is going to be too high, for which the infectious parameters there. If you're going to use steroids, which means your severe immunocompromised phase, you may land up with the worsening of symptoms. So concomitant steroid use and followed by the disease duration for almost less than 3 years, and Mayo score severity, if it is going to be more than 3 years, more than 10, that shows evidence that the patient may have adverse effect once the patient is going to be initiated on monoclonal antibiotic support. And this monoclonal antibody, always you should remember, the patient can land up with multiple infections like upper respiratory, disseminated TB, and lupus reactions, and sometimes secondary lymphomas. All those things can. But what is this thing which is most important to decide the patient prior to a monoclonal antibody? We need to rule out all possible sources of infection. We need to look for hepatitis B virus, C, HIV serology. We need to rule out tuberculosis strongly, because this kind of patients, once you are going to initiate this kind with monoclonal antibody support, the patient can worsen. I have seen multiple patients with worsening of tuberculosis-like presentation, followed by we need to stop the monoclonal antibody once and need to initiate the patient with a tuberculosis line of therapy, and sometimes the patient can land up with septicemia and other complications, and the patient may finally succumb with severe colitis, and sometimes some patients can go for high mortality. Few days before also, I've seen a young girl who was almost just 22 to 23 years, who presented to us worsening of symptoms, fan colitis picture in the background. We are decided to initiate a monoclonal antibiotics. This kind of patients will have shown a worsened response rapidly after initiating. The patient developed with tuberculosis and worsening of symptoms. The patient landed with septicemia. So always you need to be very, very cautious if you're going to initiate this kind of patients with monoclonal antibody support. So this is how medical rescue therapy is being working out, like azathioprine, in cyclosporin and infliximab. That's what I've been discussed with you. If the patient doesn't show any significant response, the patient can go for colectomy. Cyclosporin with infliximab. So what is the most important thing? We can either choose this or that. But considering either cyclosporin, the switching over between cyclosporin and infliximab most of the time will not be recommended, because if you're going to switch over between these two molecules, what will happen? The patient's clinical scenario definitely is going to still worsen off. And what is the most important thing? Sometimes what is the thing which makes the effectiveness of your molecule to come down? Like if the patient is going to have ADA, which is nothing but anti-drug antibodies. So if the patient anti-drug antibodies, if it is going to come down, if the patient is having increased clearance of the drug, and this kind of patients can have a less of effectiveness and infusion reactions, or if the patient is not adhering to the therapy. These are all the other things which is being shows the less loss of effectiveness for your monoclonal antibody support. And there are multiple other papers, multiple other molecules to be considered in the management as per your various position statement, ECO guidelines, and ECG. There are so many other molecules can be considered, but the proven effective benefit from vedolizumab also can be considered. If you're going to look into that, in the management of acute severe UC, substituting infliximab, we can try. This is nothing but a alpha 4 beta 7 integrin molecule. Inhibits the binding of lymphocytes to MATCAM, which means a gut specific intestinal mucosal addressing molecule MATCAM1, which is going to. And vedolizumab, there's multiple trials have been there, Gemini 1 and Gemini 2, and the initial dose will be around 300 milligrams, and we need to maintain the patient with 300 milligrams IV every 8 weekly, followed by the induction of 0, 2, and 6 weeks for this kind of patients. And adalimumab also other molecules. Frequently we have been in a trial with adalimumab also, and we have been trying with infliximab also. And when you're going to initiate the patient adalimumab support, we can give initial dose of 160 milligrams and second dose of around 80 milligrams 2 weeks later, and maintenance always around 40. Subcutaneous administration can be given, and followed by the maintenance dose to be continued. And this is all the ultra trial. So many other trials are being there for to assess the evidence whether the adalimumab support is being working or not. So was an 8-week study evaluating induction of clinical remission in those who are not previously treated with TNF inhibitor, and shows adalimumab to be superior in ultra 1. And Ultra 2 is nothing but a 52-week to gather long-term data and to improve assess the efficacy and safety of adalimumab in the maintenance of remission with proper mucosal healing is there when compared to placebo molecule. So this is nothing but a golimumab can also be considered in the management if you're going to use at a dose of around 200 milligrams subcutaneous at week 0, followed by 100 milligrams subcutaneous at week 2, and we need to maintain the patient every 4 weekly for 100 milligrams subcutaneous to be done. And so it's nothing but a human monoclonal IgE antibody can also be considered in the patient with moderate to severe ulcerative colitis. And when you're going to tackle a patient with severe ulcerative colitis, always you should remember the various complications like toxic megacolon, which is most important dreadful complication because of your electrolyte disturbance. What is going to happen? Various risk factors like dyselectrolytemia and full bowel preparation medication like anticholinergics and over-the-counter medications. If you're going to use, you're going to see your colonic dilatation, transverse colon diameter is going to be more than 5.5. It shows evidence of toxic megacolon, and this presentation will vary from around 1 to 2.5. And once a patient is having this kind of presentation and may develop almost around 5% of severe UC can land up with toxic megacolon. So always you need to identify and prompt institution, nil by oral, IV support, broad spectrum, fluid management, intensive therapy, clinically assess the patient for worsening of symptoms. All these things has to be taken over if you're going to manage a patient with UC. And lower threshold, because this kind of patients can go for surgical intervention, has to be done for this kind. Once the patient being landed with toxic megacolon. And the second complication in the management of severe UC, always if you're going to use colonoscopy, if you're going to inflate too much of air, or if you're going to worsen the clinical presentation and the background of polyposis and other kind of symptoms, the patient can develop a perforation. So once the perforation, if you're going to assess the abdominal sign, the hair and the diaphragm, other things, if you're going to make it to that, and renal shadows, if you're going to look into that, the patient can go for this kind of surgical intervention has to be taken over promptly if you're going to manage a case of perforation. And when you're going to consider this patient for surgery, like the toxic megacolon, perforation, severe hemorrhage is a final option. Surgical indication is a final option, and patient can be considered for colectomy. And the patient always need to survive. Surveillance for the colonic dysplasia carcinoma. If the patient shows evidence of pediatric age group severe growth retardation, once the patient is intolerable to medical therapy, or any other systemic complications is going to be supervened in this kind of patients. The surgery plays a major role for this kind of patients. But this has been taken from World Journal of Gastro. What they mentioned is the mortality according to day of surgery. So when you're subjecting the patient for more than 5 days of the initial presentation, if the patient is going for, there is possibility of mortality will be high for this kind of patients. And always see emergency surgical management has to be decided promptly within a period of 3 to 5 days if you are going to do or not. It's the most important thing if the patient doesn't show evidence of response to medical therapy. And most centers advocate a 3-step surgical procedure, nothing but subtotal colectomy and ileostomy with the rectum left in situ. And the second one, the wall of rectum and inferior mesenteric artery should be preserved, which facilitate further surgery. And the second step considered could be ileal pouch formation. The third one will be ileal pouch anal anastomosis, IPA, to restore the normal continuity can be tried. So these are all the various reconstructive procedures can be performed over a period of 6 months after the primary repair. So this is how the schematic diagram, various surgical interventions that is out of discussion right now. So we can go for ileostomy with subtotal colectomy and formation of Hartmann's pouch, along with a Brooks anastomosis. All these things can be considered. A conventional ileostomy with total proctocolectomy can be tried, and restorative proctocolectomy with ileal pouch and anastomosis can be tried. So various surgical interventions are there if you're going to manage a patient. So always you should remember the patient is going to present with acute severe ulcerative colitis, which means your Mayo severity is going to be worsened. Your ulcerative colitis severity indices, if it is going to be there, as per your 2-low-1 WITS criteria, if the patient doesn't show evidence of a stool criteria of more than 6, along with your CRP worsening, ESR worsening, clinical parameter worsening, hemoglobin is worsening. So all these patients to be assessed in the intensive care support. First line of always steroids to be considered, and you need to assess the good response of steroids within a period of 3 days, and we should not continue steroids, IV corticosteroids for more than 7 days, and IV steroids is the most important thing. Once the patient is not responding, second line therapy has to be decided promptly, or else we can stop the patient second line therapy as early as presentation itself. So second line therapy, rescue therapy like azathioprine, cyclosporine and tacrolimus can be considered in the management, and if shows no response, we can consider biological also like infliximab, adalimumab, and vedolizumab and golimumab. All these things can be considered, and once all this medical rescue therapy, even if it doesn't show much worse improvement of a clinical presentation, the patient may finally land up with colectomy and other things. And one important thing, what I'm supposed to say about this, we need to do once a patient is being diagnosed with ulcerative colitis, once a patient is going to improve its symptoms, the surveillance for colorectal carcinoma is most important, and we need to do for a period of around, every 1 to 2 years, we need to do a surveillance colonoscopy for this kind of patient to assess the patient is progressing for dysplasia or carcinomatous changes. And there are multiple new modality of endoscopic therapy like chromoendoscopy and various wideband endoscopic therapy. All those things, available to assess the patients going for early dysplastic changes is there or not. Always you should remember the early management is the most important thing. Counsel the patient and tackle all the infections and look for pseudomembranous colitis, antibiotic colitis, and look for the patient of CMEs, chronic cytomegaloviral infections. And all these things has to be ensured, and proper assessment whether the patient is going for tuberculosis is there or not. All these things has to be done in a proper manner before switching over the discussion of acute severe ulcerative colitis management. And with this, I would like to rest my presentation and thanking you all for patient listening. And I'm happy to take up your questions if anything is there to take on. Any questions?
Hello, doctor. Doctor, there are questions in the chat box.
Yeah, madam. Please, you can post your questions right now to me. I will be discussing with you all. Which is the most? So you want to share the questions? You want to discuss the questions with me?
Yeah, doctor, I'm facing some issues with the internet. I'm trying to share the questions with you.
Okay. See, I will be taking on these kind of questions. What is the most preferred? Which is the most preferred corticosteroid being used in treatment with acute severe ulcerative colitis? As we all know, hydrocortisone in the initial phase and dose will be around 100 milligrams every 4 to 6 hourly, and we can consider this kind of patient for an initial period of 3 days only. So if you're going to manage a patient with steroids, or else you can give a methylprednisolone also in the management of UC at a dose of around 60 milligrams. So followed by maintenance dose of steroids can be considered. This is the first question what have been taken over. And the second question is, which is the most preferred corticosteroid use? And that's what the same question have been mentioned, what have been discussed. And how to monitor the treatment and what are the various preferred tests and how frequently they will be performed. So how to monitor the treatment means we need to do a surveillance colonoscopy. The preferred tests like basic baseline ES or other tests, baseline clinical parameters, based on clinical assessment, your stool frequency, and surveillance colonoscopy. Whether the patient is showing evidence of improvement of signs and symptoms is there. This is how we are going to monitor the patient with treatment. Or probiotic. Next question is whether the patient is having any evidence of probiotic improvement. Any probiotics being recommended in the management of ACU. As you all know, the Femicoids and bacterides ratio are being significantly altered, and plasminogen Z levels also been altered in case of management with IBD. As what been Dr. Karthik has been posted this question. If you're going to discuss, there are multiple probiotic strains like Lactobacillus GG and other things like Saccharomyces boulardii. All these things can be considered in the management of acute severe. But once a patient going for acute severe ulcerative colitis, There is no much of role of probiotic support, only for monoclonal and other things to be taken on. And fecal microbiota transplant can be used in this kind of patients, mild to moderate. And mild to moderate FMT also been various papers been showed evidence of some trials are there. And for patients with severe colitis and acute severe precipitation, the role of probiotic is definitely a questionable issue. Next to that, Dr. Gopal Swami, is there any specific nutritional recommendations there? See, if you're going to look into that, see, what do you mean by this malnutrition if you're going to manage a patient with acute severe ulcerative colitis? Always you should remember that we need to go for a specific enteral nutrition is the most important thing, and total parenteral nutrition is always not much of recommendation. Any specific, always you need to target the population who shows evidence of malnutrition, like weight loss more than 10 to 15% over a period of 6 months, and BMI if it is going to be less than 18.5, and if the patient's albumin, it's a very significant pointer, can be used for assessment of a clinical picture. Once a patient's albumin, if it is going to be less than 3, the patients can land up with worsening of presentation. So always in these kind of patients, we need to subject these kind of patients the proper nutrition support, and the protein supplement has to be done in a proper manner. And apart from that, the carbohydrate load has to be done in an equal manner. And fat and all these things, the cholesterol preparations also being and biosimilars also being available as a specific nutrition recommendations can be tried if you're going to manage a patient with this kind of. And short chain fatty acids also, there are some evidence of papers are being tried with specific nutrition recommendations. And the main thing, if you're going for a managing a patient acute severe UC, early initiation of enteral nutrition is the most important thing to be discussed. Any other questions, is there? What happened to the guest person?
Sir, good evening, sir.
Yes, good evening.
Sir, when can we stop biologic, sir? This immunomodulator, sir. Once patient response and maintenance therapy for 2 to 3 years, can we stop and see, sir?
Always we can stop the biologicals also when you're going to subject the patient with. So once a patient says that, if you're going, for example, if you're going to subject the patient with infliximab support every 8 weeks for a period of around 52 to 54 weeks, if you're going to give, and once the patient shows some evidence of response, we need to stop the patient biological support, and we need to see whether the patient is responding or not. So biologicals, all these things can be stopped once a patient shows the evidence of a clinical response, and provided that most of the time the steroid tapering is the most important thing. Over a period of 8 weeks has to be done in a prompt way if you're going to manage a patient with UC.
Sir, that means the patient can be all medication free after.
Depends upon your clinical
try that.
presentation and clinical worsening of symptoms, sir. So what is the condition you are going to treat once a patient is going to show evidence of acute severe ulcerative colitis? The low dose of medications has to be continued for a longer duration. Sometimes there are some papers and trials of even azathioprine can be considered for a period of almost 2 to 3 years also been tried in the management of ulcerative colitis.
Yes, sir. And this NUDT versus TPMT, sir. In Indian scenario, it is told that NUDT is better. So what do you say, sir?
Always say Indian scenario NUDP, what you mentioned is definitely more better when compared to use a TPMT, because TPMT, the potency and the cost and other issues have been there. And moreover, if you're going to use NUDP, the definite assessment and the more sensitivity for that parameter to assess a clinical progression and the early response is most important, can be considered. So NUDP definitely will be more important rather than going for TPMT assessment right now in the management of UC.
So NUDT and TPMT both, or what do you say, sir? Should we get both, or just NUDT is more than in Indian scenario, sir?
NUDT is more preferred than rather than going for TPMT, sir.
Yes, sir. Thank you, sir. Thank you so much, sir.
Thank you. Any other questions, sir?
I ask one question, sir?
Yes, sir.
Sir, fever in ulcerative colitis, as it, sir, even in your case also, the patient has presented with fever. So
Yes, sir.
whenever patient comes with, we think that it is because of UC or like, is it because of any other infection? See,
So
the case
always in the
reproduction.
background of UC, we need to rule out other possible infections, because you always should remember UC will mimic Clostridium difficile, UC will mimic Shigella, UC may mimic Salmonella, UC may mimic Campylobacter and other infections also. So it could be a supervening of all those pictures. Any patient who shows evidence, even if the patient previously diagnosed with the background of fever, doesn't mean that the patient is having only because of worsening or flare of symptoms of UC. We need to always rule out the possible source of infection. That's the most important thing if you're going to manage a patient with ulcerative colitis.
Yes, sir.
Because
So
most of the
it
time
will
will
be
be on long-term
excluded.
steroids. The patient will be on immunosuppressive phase, and moreover, your fever will not be a significant pointer to assess your severity.
Yes. Thank you, sir. Thank you so much.
Yes, yes. Any other questions, sir? If there's no further questions, I think for me to wind up the session right now. And thank you, Sipla, and thank you for all the participants who are being here to share some knowledge what's being happening in the
And
field of
thank you, sir, on
ulcerative
behalf
colitis.
of entire Cipla team, sir.
Thank you,
It's
sir.
a excellent.
Thank you. So I think some issues in the internet connections, so no issues about that. So thank you very much for patient listening, and thank you all to make this event a reasonable progress. Thank you, sir.